Good evening, everybody, wherever you are. Um, my name is Fayaz Ahmed, and I am a neurologist in Hull and East Yorkshire, and I'm also the educational officer for the British Association of the Study of Headache. This is our fourth webinar of the series 2021. We have been through some history taking, secondary headache, and pathophysiology. And today we are going to talk a very good clinical topic of how you treat migraines as an acute attack and preventive treatment. And we would have the perspective of secondary care and primary care so that it helps all of our viewers that are attending the webinar. I'd like to thank our panel to giving us their time speaking in this webinar. I'm also grateful to the BASH Council for all their help in organizing these webinars. I'm also grateful to our sponsors and above all, I think all the audience who have been attending these webinars in massive numbers. So these are our sponsors with the Unrestricted Educational Grant. We have got this webinar approved for 2 CME point. So if you attend all the 12 webinars, you don't have to do anything else. You get 24 external CME points. We are not issuing certificates. This is the code that we usually give, and please provide us the feedback, which is obviously essential for the college to continue to provide us the approval. The webinar obviously is live, but the recording is available on iCloud from tomorrow or 1 month. And after that, it is on the YouTube channel of BASH, where you can see all the previous webinars as well. So that's an opportunity. If you have missed the live event, you can always go back and look at the previous webinars. So this webinar, we're going to talk about acute and preventive treatment. And the next webinar is on the 28th of May. It's usually the last Wednesday of every month. Apart from December, because of the Christmas New Year, we'll be doing it on the 15th of December. So in the next one, we would have Peter Goudsby, Alina, and David Watson speaking on the trigeminal autonomic cephalalgia. So without wasting any time, let me introduce our first speaker. Is Callum Duncan, who is said to me that he's a jobbing neurologist in Aberdeen. So he sees lots and lots of patients. If you have heard of SIGN guidelines, you probably have. The reason I'm saying heard of, because we have attendees from all over the world. 30% of our audience comes from the rest of the world because the invitation goes everywhere. He's the chair of the SIGN guideline, and he's currently the secretary of British Association for the Study of Headache. So he'll be talking about the acute treatment. Now, before I hand over the podium to him, if you keep typing the questions, we may answer your questions on the Q&A. And if the questions are very interesting or something that we cannot deal with just replying on the text, we would do it on the live question answer sessions. We'll have all the 3 speakers, and then after that, we would have maybe 20 to 30 minutes of live discussion. So Callum, the dice is yours, acute treatment.
Okay. Thank you very much, Fayaz. I'll just share my screen. Okay. Can you see that? Yes?
Yeah, that's brilliant. Thanks, Callum.
Okay. So thank you very much for inviting me to do this webinar. I'm a jobbing neurologist, so I see lots of patients and have an interest in headache. And this is very much a practical talk on the acute management of migraine. Migraine headaches are debilitating, cause significant problems for patients, and are often under-recognized and under-treated. So it's important for us to treat them actively. So my disclosures, I have no industry disclosures. I, as Faya said, am chair of the ASSIGN guideline. And what I'd like to sort of cover today really is about principles of management of treatment, acute treatment, the individual acute treatments and what may be emerging, acute treatment in pregnancy, which is actually less complicated than we thought before. If we've got time, status migrainosus, and then remember about medication abuse headaches is really quite important in this context. So the number of guidelines that we have available to us. So the NICE guideline was produced in 2012. The SIGN guideline was in 2018 as an update from the 2007 one, so it's purely on pharmacological management of migraine. And we have quite a useful patient guideline as well that can be utilized, and you'll see the web addresses there. Professor Ahmed, along with Dr. Weatherby, Dr. Bahar, and Dr. Tiagi, did the BASH National Headache Management System, on which a lot of this talk is based, and that's a very useful resource for both patients and for clinicians, and the web address is there. So if we think about acute treatment, it's important really to take treatment early. If it's wait till it's late, then it's going to be less effective. We have single high dose aspirin and non-steroidal often as first line. I'll talk a bit about what stepped and stratified treatment means. And then there's combination treatments. And certainly the NICE guideline, which did network meta-analysis, came to the conclusion that combination treatments are more effective than individual treatments, and therefore suggested that's what you should do for the majority of patients. So combination treatment certainly can work more effectively than treatments given individually, although you will do it depending on your patient. Think about route. You know, most patients with migraine are nauseated and don't usually vomit, but some people vomit early, and if someone vomits early, there's no point giving them an oral treatment as it's not going to be absorbed, and so you need to think about nasal and subcutaneous. It's important to think about route. And it's important to think about rescue treatment. So have your triptan if your non-steroidal doesn't work. If a triptan doesn't work, then there's no point repeating it, but if it partly works, then it's worth repeating it at 2 hours. Sumatriptan 6 milligrams is the most potent treatment and is useful as a rescue treatment, and injectable diclofenac can be useful. And really, when you're talking to patients about acute treatment, remember about medication overuse. And the best treatment for medication overuse is prevention. So set limits at the beginning when you're talking about treatment. So really, we're talking about no more than 2 days per week on average, or a maximum 10 days per month. So treat early. This was a useful study undertaken in 2008 by Professor Goldsby, and that clearly shows that when taken early, when migraine is mild, that it is more effective than when you wait until the headache is severe. So take early is important. And also, there's much less likelihood of recurrence if a treatment is taken early. We think that treatment taken with aura is probably not going to be effective, potentially because of lack of breakdown of the blood-brain barrier. And so it's when the headache is starting that you want to consider acute treatments, and you want to avoid waiting until it becomes significant. Stepped and stratified treatment. So stepped really means start with something like a non-steroidal, perhaps try that for 2 or 3 headaches. If that doesn't work, then we move on to the next step, which may be a triptan. You can do that within the attack itself. So if your non-steroidal doesn't work, then you go on to use your triptan as a rescue treatment. And you can move on to combination treatments if you don't want to try them from the beginning, but it's a negotiation with the patient. Stratified treatment is probably more efficient, and that way your patient will decide whether an attack will respond to a non-steroidal or whether it requires a triptan. So often you use paracetamol or non-steroidal for your mild, moderate attacks, and your triptan for your more severe attacks. So that's stratified treatment. And then which treatment to use. So this is number needed to treat to have pain freedom at 2 hours. And these are the treatments where there is a number needed to treat. And you can see that paracetamol really is a pretty mild treatment, with 12 patients needing to be treated to get one good response. Aspirin and ibuprofen are similar. And the bigger dose of ibuprofen, the more effective the treatment. Triptans are clearly better than non-steroidals. Sumatriptan 50 milligrams is less effective than sumatriptan 100 milligrams. And nasal preparations are more effective than oral preparations. So nasal zolmitriptan is better than oral zolmitriptan. And injectable sumatriptan is the most potent of the treatments. So you can think about that in depending on the severity of the attack. When treating migraine, we're not thinking about our classic pain ladder. So the classic pain ladder says take regular treatment and build it up the treatment if it's not effective. That is not going to work in migraine, and that is going to lead to medication-induced headache. So you want to use high-dose treatment at the onset of an attack in order to abort it, rather than regular treatment to keep the attack down. Avoid opioids and opiates. They're much less effective, and they have a much higher propensity to develop medication overuse headache. You want to go for decent doses. Paracetamol really is only useful for mild attacks, and I tend to use 1.5 grams instead of 1 gram. Aspirin 900 milligrams is a good initial treatment and works quite well. It certainly is my effective treatment. Ibuprofen, if 400 milligrams doesn't work, 600 milligrams is definitely better. You should step it up. And in fact, some people might use 800 milligrams or 1 gram. The aim is to get a big treatment in order to abort the attack rather than giving a regular treatment through. Worth combining with antiemetic, that gives an additive response. The evidence is for metoclopramide and chlorperazine. Domperidone has limited evidence, but has no central effect. Of course, there is the issue around long QT. So non-steroidals and aspirin useful, take early, and are often a first-line treatment. And remember about the antiemetics, actually they have effect on the migraine headache itself. And we have a number needed to treat of metoclopramide and chlorperazine alone of 17. So they are a mild treatment, but they do have an independent effect on migraine headache. And certainly when combined with a non-steroidal or paracetamol, they will be equivalent to sumatriptan 100 milligrams. Aspirin and an antiemetic is better at the associated effects such as nausea than paracetamol and metoclopramide. So remember to consider the antiemetics in your treatment strategy, often as a combined treatment. Triptans, so these were introduced in the early 90s and were really very revolutionary at the time. Sumatriptan is our first-line treatment. It's now off patent, and so it is relatively inexpensive. The triptans are 5-HT1B and D agonists, and the effect really is to inhibit the release of calcitonin and gene-related peptide, which is an integral part of the migraine pathway. Migraine is a brain disorder, not a vascular disorder, and one of the main issues with the triptans is they can constrict blood vessels, and that gives concern around patients with significant cerebrovascular, cardiovascular disease and uncontrolled hypertension. The effect of triptans is variable between patients, and the different triptans will work differently in different patients. So it's an idiosyncratic response. And if one triptan doesn't work, it doesn't mean another is not going to work. And so often you've got to try different triptans in the same patient to find which one works. So you shouldn't just give up because one triptan is not effective. In women, the period of menstruation is a common trigger for migraine, and for women, migraine is often more frequent and worse at the time of menstruation. The triptans do work for menstrual migraine, but they are less effective for that, and any of the triptans can be used. If you're wanting to consider perimenstrual prophylaxis, so that's a triptan taken regularly during the predicted headache time, which is usually from a couple of days before menstruation through into menstruation. And frovatriptan, which is a long-acting triptan, is the most logical treatment, but zomatriptan can be equally efficacious and would be used 2 to 3 times per day for that period. The important thing, if you're considering using perimenstrual prophylaxis, is to ensure the patients don't have migraine attacks at other times of the month, because you can end up tipping patients into medication overuse headache if you're using a triptan in more than 10 days per month. Sumatriptan is now thought to be safe in pregnancy, but the triptans, despite their long use, remain relatively underused. They have a risk of medication overuse headache as other treatments do. So most patients really have few problems. They're not strong treatments, they're specific treatments, and they're useful for the management of migraine. There are a number of fairly predictable side effects in patients, and some patients get a heavy sensation, which may be misconstrued as a cardiovascular problem, but generally isn't. Importantly, triptans are contraindicated in patients who have active cardiovascular disease and active cerebrovascular disease, and in uncontrolled or accelerated hypertension. The studies on triptans were done in patients aged 18 to 65, and that's where the license is, but that doesn't mean they're not useful for patients older than 65, and there is no age limit on the use of triptans, but clearly cardiovascular and cerebrovascular risks need to be actively considered in patients over 65 when prescribing triptans. So these are the triptans. So almatriptan, elatriptan, rizatriptan, sumatriptan, and zomatriptan are all short-acting triptans. And frovatriptan is a long-acting triptan with a 26-hour half-life, naratriptan with a 6-hour half-life. And so that can predispose to what they might be useful for. So the first line generally is sumatriptan 100 milligrams. In comparison to sumatriptan, the lower adverse effects are with almatriptan, which is equivalent or better in potency to sumatriptan. So it's a very useful treatment if there are significant side effects. Frovatriptan and naratriptan, which have a longer and slower onset of action, can also be useful if there are side effects for patients. Elatriptan, rizatriptan, and almatriptan have a better 2-hour pain response, and so may be more useful for patients who have more significant attacks or patients who are not responding to things like sumatriptan. And there's a lower recurrence rate in a long-acting triptan, such as frovatriptan, or in a more potent triptan where we're hitting the pain harder, as in elatriptan. So that again is useful to consider. And this is again detailed in the BASH treatment pathway. So if we think about when to use triptan, so sumatriptan is going to be a first line. Use 100 milligrams rather than 50 milligrams because it's more potent. If the side effects, almatriptan, frovatriptan, or naratriptan, starting usually with almatriptan. If there's early vomiting, think about nasal or injectable treatment. If it's an inadequate response, I would usually use a non-steroidal or aspirin first, then move to triptan, then move to a combination treatment. But if the headaches are more significant, you may want to move directly to combination treatments. You can add an antiemetic, add naproxen, which is a long-acting non-steroidal, or add paracetamol. And NICE recommend that we do this routinely. Severe headaches, rizatriptan, elatriptan are useful, or a nasal or injectable preparation, or a combination preparation. And if there's recurrence, hit it hard with a more potent triptan such as elatriptan or rizatriptan. combine it with a long-acting non-steroidal such as naproxen, or use a long-acting triptan such as frovatriptan. In pregnancy, this can be a problem, but often isn't, because migraine does tend to get better in pregnancy, particularly migraine without aura, and that's usually in the second or third trimester, so usually it's worth waiting to see if the migraine does improve. We're usually trying to avoid unnecessary medications, but we shouldn't undertreat patients. Paracetamol, which is clearly a mild treatment, is safe at all stages of pregnancy and certainly will be the treatment of choice for mild to moderate attacks. Ibuprofen, there's a lot of debate about ibuprofen and whether ibuprofen might theoretically have risks in pregnancy, but in the first 2 trimesters, it's recognized to be safe. It clearly shouldn't be used in the 3rd trimester because of the risk of closure of the patent ductus arteriosus. And we now have quite good evidence that sumatriptan is safe in pregnancy. In quite a big registry and a meta-analysis of registry data, there is no evidence of an increased risk of congenital malformations or prematurity. And in quite a big cohort study, there was no evidence of an increased risk of spontaneous abortion. The evidence really is mainly on sumatriptan, so that's what I'd be more comfortable with, rather than the other triptans. And aspirin, given the effect of Reye's syndrome, should be avoided in doses for migraine. In pregnancy, clearly it may be used at a low dose of 75 milligrams for other conditions. So those are the treatments that we have, and things haven't really changed an awful lot over time. There are a couple of emerging treatments, and in particular, lasmitamab may be potentially useful. So that is FDA approved, and it is going to undergo a nice appraisal in the early part of 2022. This is a 5-HT1F agonist, so it's in the same pathway as the triptans, but the 5-HT1F pathway does not have effects on blood vessels, and therefore there is thought not to be a risk of cardiovascular and cerebrovascular events, and certainly the trials, particularly ones used in patients with cardiovascular profiles, have been reassuring. They are likely to be equivalent to triptans, and certainly the pain freedom at 2 hours, which in the lasmitamab trials is about 30 to 40%, is equivalent to sumatriptan 100 milligrams in the Cochrane reviews, which again came out about 30% with a similar placebo response. So it looks to be equivalent to triptans, and therefore, if approved in the UK, may be a useful treatment for patients who have cardiovascular problems and where triptans would not generally be used. The CGRP antagonists of small molecules have also been FDA approved. They're probably less effective than the triptans and lasmitamab. There's currently preventative trials underway, and it's possible that they may be more of a preventative rather than an acute treatment. The thought is that they're not going to cause medication overuse, and they're potentially quite attractive from that perspective. So moving on to status migrainosus. Status migrainosus is essentially a normal migraine, but more severe, more prolonged, and persisting for 72 hours or more. It generally occurs in episodic migraineurs more often than in chronic migraineurs in general, but there is obviously the risk of being left on medication and the risk of developing medication overuse headache and developing chronic migraine. So it's important to try and manage. These patients are often quite difficult, and the propensity to be seen in accident and emergency and in acute medical wards. And they're often harder to treat than standard migraine, which is why they do sometimes end up in hospital. Sumatriptan subcutaneous is clearly the most potent triptan that we have. And whilst the mantra of treat early is really quite important, Still in this setting, in patients who come into accident emergency with status migrainosus, sumatriptan can be effective and is definitely worth considering. So in these patients, it's worth using sumatriptan as an abortive treatment to try and stop that prolonged attack. IV aspirin and IV paracetamol, which are again widely available, can be very useful in this situation as well, and again are worth considering, as is an parenteral IV or IM antiemetic. So these three can be quite useful strategies in patients who present with status migrainosus, which can be quite difficult to manage. IV valproate can, and there is some loose evidence that this is potentially useful. Clearly, there's an issue in that many migraineurs are women in childbearing years, and there is clearly the MRHA guidance for use of valproate. This is probably not a useful strategy for the majority of migraineurs with prolonged headache, but maybe considered for some, and certainly would require a pregnancy test prior to use. Steroids, so IV dexamethasone has evidence that it is useful in this situation, and oral prednisolone tapers are commonly used and can be effective. There's anecdotal evidence for that. Clearly, steroids present a problem in patients who present with this frequently, and really should be reserved for infrequent use, and certainly no more than 3 times per year. Blocks, so we use blocks for treating headache disorders. They're more useful for things like the trigeminal autonomic pathologies, but they can be useful in migraine, although there's much less evidence. The evidence base is poorer. The greater occipital nerve block accessed at the greater occipital nerve, usually in a suboccipital injection, is potentially quite useful in this situation and can be used if you have access to that. And then really finally, considering medication overuse headache, because really one of the most important things is to ensure patients are treated effectively and don't end up with medication overuse headache. Prevention is definitely much better than cure. In practice, this can sometimes occur quite quickly, although the classification would suggest it should be there for a few months more, but it can occur relatively quickly in some patients. Migraineurs are really particularly prone to it, particularly migraineurs taking pain medication for other reasons. And people who take pain medication for other reasons can then go on to develop chronic migraine with medication overuse. All treatments can do it, and the main thing is to ensure that we're not giving acute treatment too often, restricting it to 2 days per month, and we need to be thinking about preventative treatment in patients who are having more frequent migraine. It's often migraineurs, apologies for that, often migraineurs emphasize their severe headaches. So it's really worth ensuring that they're not having more chronic headache pattern. So ask about milder headache days, and certainly ask about crystal clear days. You know, if someone is having very, very few days where they have no headache at all, they may actually have medication abuse headache, and they may not volunteer their over-the-counter treatments. So it's important to look specifically for that. And the main real thing when you're considering medication overuse headache is to consider it and to recognize it and to try and address it. Clearly withdrawing treatment is important, and withdrawing treatment can often be effective. Okay, the best strategy is going to be withdrawal. Preventive treatment can be effective for some patients, and it's important to give the patients those advice. Okay, so that's me finished. I'm happy to take any questions either now or at the end.
Right, thanks, Callum. That was good. I hope it wasn't your mobile phone, because I think people might have thought that I was giving you a signal that 20 minutes are over. Yeah, no, that's good. I've got quite a few questions, but I think we'll take all the questions at the end. So if you don't mind, stop sharing your slide. Our next speaker is Brendan Davies. He's going to talk about prophylactic treatment in migraine. Brandon is a consultant neurologist in Stoke-on-Trent, Keele University. He organizes, pre-COVID time, he used to organize registrar training weekends in Keele University. Brandon is currently the vice chair of the British Association for the Study of Headache. He's also a trustee of the Migraine Trust, and he's also in the Association of British Neurologist Headache Advisory Group. So Brandon, dice is yours.
Right, thank you very much. Can you hear me first of all before I start speaking?
Yeah, I can hear you. Definitely.
Perfect. Okay. So I'd first of all like to thank Bash and all the attendees for giving me their attention on a Wednesday evening. I'd like to thank the Migraine Trust and ask everybody who's on this webinar to look at the Migraine Trust website, because it's a really useful thing. A few declarations of interest. Some people pay me money for my opinion for what it's worth, and I have some other clinical interests and NIHR commercial trial interests. So what I'm going to try and do in 20 minutes is cover these 4 areas. Look at the preventative treatment landscape before COVID, and look at prophylaxis specifically, and some of the problems and opportunities. Look at what's happened during COVID times, the publication of all the nice guidance about these new therapies, and has it made any difference in terms of the trial data, and pragmatically what it's going to do for us. Talk about something we probably never talk about, is when do you stop treatment, and what happens when you stop treatment, and if we have time, just talk about what's coming next in preventative. So everything migraine diagnosis is key. So making a diagnosis is the first step. Educating people about what may or may be responsible for giving them some of their attacks. Lifestyle modification and trigger management has always been big press in prevention, but probably may not be as important as we think. But drinking appropriately, having regular meals, having good sleep patterns, avoidance of stress if it's possible, are thought to be the first things one thinks about doing when one tries to manage and prevent migraine. And up to 40% of people can be benefited by approaching this regime. But I'm going to talk largely about pharmacological treatments and prophylaxis, and I'm not necessarily going to talk about some of the other things, but it's important to know that they are there in the preventative treatment armamentarium. Where I was involved in the NICE guidelines, and I was very proud of these, being involved in this in 2012, but I reflect back on them and I think they were probably not fit for purpose, although we're not allowed to diss the NICE guidelines, so that's probably all I can say, because I think they were limited in their scope. But what's really important is that they need to be taken in the context, and what now is available to us is, as Callum pointed out, is the SIGN guidelines and the BASH National Management System for Adults available at these websites is imperative if you are going to standardize and produce effective evidence-based care for migraine prevention. And I commend both of them to you. They're both free to download. You'll see this slide a few times because I think it's really important. So when really are you going to consider preventative agents for migraine? Lots of people just do not want to take medications, or they aren't aware that medications are available. So the first thing and the simple thing to think about is a frequency issue. When migraine is starting to affect daily function, people usually start to present to primary healthcare practitioners. About 50% of people never see a doctor for their migraine. They manage it with over-the-counter medication. But when the frequency starts to get to about 6+ days a month, you certainly should be starting to consider a preventative therapy, because acute medications alone may not be sufficient to manage their symptoms and may in the longer term lead to a medication overuse problem if not prevented. If it gets to 8 days and certainly 10 days a month, my view, and it's consensus as opposed to evidence-based, that I'd strongly advise initiation of a preventative agent, because you are then starting to get at high risk of medication overuse. And there are some good studies to show that if you have a headache frequency in around the 8 to 10 range, within about a year, if you don't intervene, you're likely to have progressed to 12, 15 and chronic migraine. It goes without saying, if migraine significantly interferes with daily therapies that my colleague Callum has just described, then prevention needs to be considered. Another group of people are the people who can't take conventional acute abortive therapies, the people with gastroesophageal reflux, the people who've had a stroke or have ischemic heart disease or have had a TIA or have significant vascular risk factors, which means that triptans are largely contraindicated, non-steroidals can't be used, and we really don't want to go down the opioid route for the reasons that Callum has outlined. Then there's some slightly more nebulous and rarer things. People who have frequent aura symptoms. It was noticeable, as you'll see from Callum's talk, they didn't talk about acute treatment of aura, because we haven't at this time got a definite acute treatment of aura. There's a device which is proposed to be beneficial, but the data is not fantastic. So frequent aura symptoms or rare aura subtypes, hemiplegic migraine, or what used to be called basilar type migraine, or migraine with brainstem aura, if they're frequent, need to be managed largely with prevention. And then there's something called vestibular migraine. I'm just going to mention it rather than talk about it, and we can take some questions about that if you want to ask a bit more about that. And finally, migraine doesn't kill you, but actually it's a patient preference. There are some people who they want to take prevention. They want less migraine. And if you ask people with migraine what they want, and the Migraine Trust has done that with their surveys, they want a cure for migraine. They want something which is going to give them less attacks and less impairment. But there has to be considerations around teratogenicity and adverse effects, because this is a condition which predominantly affects females 3 times more than males in their childbearing years. So again, the issues of prevention raise issues around women's reproductive health. So this is a really busy slide, and it's available in all those documents, just telling you all about the different options that are potentially there before COVID. And I've always called this the tabs, the jabs, the mabs, and we got some zaps. And I'm not going to talk about the zaps. And it's really important to note that most of these medications have evidence derived from lower frequency migraine. It's only recently have we had good clinical trials in high frequency migraine and what's called chronic migraine. And you can see here that the ones in yellow are the ones which have got really good significant evidence, and the ones with asterisks have got good evidence in chronic migraine. So migraine occurring in more than 15 days a month for more than 3 months. So you'll see from this massive list of medications that we all prescribe that the actual evidence base is far from ideal. That hopefully will change over the next 10 to 20 years as new therapies come through. So which is best? I often get asked, which should we start first? Well, it's all about efficacy versus tolerability. All the drugs none of the drugs have been shown to be better than each other, but actually some are better tolerated than others. And now with the new high cost drugs coming through, cost effectiveness as well as clinical effectiveness has come into place within the United Kingdom, particularly within England, with nice appraisals. And if you're going to talk about efficacy, what is an adequate treatment response? And I'm going to talk a little bit about that, but hopefully get people to ask questions about that, because that's really challenging. So outcome measures you need to think about. If you're starting prevention, you need to be thinking about, what am I expecting the preventative treatment to do? Don't just prescribe and forget, prescribe and review. Reduction of monthly migraine days, that's something tangible. But actually sometimes people just want less headache. Total abolition of migraine attacks might be an unreasonable target, but actually at least you need to have some kind of reduction target. Do you want them to have less than 30%, less than 50%? Do they want their frequency to go down by that time? And you can calculate that. if when you're taking the history, you ask them about what's your average number of days of headache a month and how many of them are migraine, and if you have chronic migraine, you think about, if I can get a third less of those, actually that's a tangible target rather than just prescribing. And when they come back, oh, it hasn't worked. Well, actually, what's the data say they haven't worked? You may need to keep diaries. And there's some quality of life scales. Again, which do you choose? I'm not going to suggest you choose one or other specifically, but there's something called the HIT6, which is available, and that looks at the impact of migraine. And there's some good data to show it can be useful instead of just counting migraine days. And one of the things I think is missing from outcome measures is what's called a sustained treatment response. When I see people with migraine, they don't just want migraine, which is better for a month or two. They want migraine, which is better for 6 months, 12 months. And if you ask most people, they want to be cured. So sustained treatment response is really important. So think about, actually, are you just having a bit of a blip, which is good for a few weeks, few months, which might be a placebo response, or are you having a sustained treatment response, 30% or 50% reduction? So think of those when you're prescribing, and think about what targets you're setting yourself. In terms of choosing which one, these are the things you need to think about. Have they got a condition that might be exacerbated by the preventative? So if they've got asthma, you're not going to give beta blockers. If you've got tremor, you want to give beta blockers. If you've got hypertension, you might want to give candesartan or a beta blocker. But if you've got Raynaud's, you might not want to do that. Some of the drugs make you more obese. It's not one of the drugs. And the current concept in UK migraine care is there's a first-line drug, we'll try that. We'll try a second-line drug. If that doesn't work, we'll try a third-line drug. And if you fail on 3 oral preventatives, you then become eligible for these new high-cost drugs, cranial Botox, and some of the monoclonal antibodies. But actually, there are other drugs over and above those 3 third-line agents. The current first-line drugs which we consider are beta blockers, of which the commonest is propranolol, metoprolol, and nadolol. Some are once daily, some are twice daily. The tricyclics, amitriptyline has the biggest evidence base, but nortriptyline and dosulipin are better tolerated. Candesartan, which with doses up to 8 milligrams twice a day, which has data from 2 trials. Topiramate, which probably has one of the biggest evidence bases, but the tolerability is an issue. Pizotifen, which is commonly known, but actually the evidence base isn't great, and obesity and side effects can be a problem. Sodium valproate, which can't be given to ladies of childbearing age because of teratogenicity issues. And then some drugs which you may have heard of, but are not licensed, but actually are approved in Europe and beyond, and are very safe and actually cheaper than some of the expensive drugs, one called flunarizine. So these are those drugs. And this is not an extensive list. And lots of these drugs are available in those guidelines that you've seen. And you need to be thinking about a starting dose, a slow incremental going low and slow, and having a target dose that you want the person to be on for at least 2 to 3 months to see if it makes any difference, with a view to increasing to a maximum target dose to see if they are truly non-responsive to that drug. And non-response means either they've been on it for long enough and it hasn't achieved the target you set, they've had side effects which have stopped the drug, or they've had safety issues which stop the drug. But you do need to try and escalate it to the maximum tolerated dose if you can. And patience is needed, and counselling of the patient around expectation is paramount. So let's talk about responder rates in trials. These are some studies that have been done. I haven't put the exact numbers in the studies, but you can see in lots of these studies, if I give somebody Smarties, so a placebo, 20% of people will have a 50% response. So giving blue pills is good, but actually it's better to give drugs that work. And topiramate, propranolol, candesartan, valproate, and if you look, and I haven't got all of the drugs that we use, I haven't got tricyclics and pizotifen in here, all appear to give about a halving of migraine frequency in episodic migraine in about half the people you use, you can see. So it's important to realize that you will only see about half the people you give these drugs to have a halving of their frequency. So these drugs are okay, but they're not fantastic. and they've looked at this in a bit more detail, and they've looked to see whether one is better than the other. And there've been some trials comparing one with the other, never powered enough to show a significant difference, because actually that's not commercially useful. But you can see from all of these, from a big statistical meta-analysis, they all have data to support them. But actually, if you ask me, which is the best, I'll say, I don't know. It's horses for courses. It's individualized medicine. So again, I'm going to send you back to these documents, particularly the National Headache Management System for Adults, the BASH system, which has data about target dosages, durations. So then we move on to the jabs. We've talked about the tabs, so let's talk about the jabs. This is the Botox pathway. And those people who failed on 3 agents, 3 oral prophylaxis, start to become eligible for this. And this is for chronic migraine only. So people having headache more than 15 days a month for more than 3 months or more, having failed on 3 therapies. And they can have treatment every 12 weeks on 2 occasions. And if they see a 30% reduction in their headache days, then they can have continuing therapy. If they have revision down to low frequency migraine, episodic migraine, the current guidance suggests they stop, which doesn't make sense, but that's what the data show. So that's what the guideline is. And if you don't respond after 2 treatments, you come off the pathway. And this is the data, and you can see here in general about 40%, 50% have a 50% response. So if you go back to those oral drugs, it's about the same treatment response, but actually this is in chronic migraine, so a higher frequency migraine, and these are people who have a much higher frequency and you can see from this graph that over time that frequency reduces, and my colleague Professor Ahmed can probably give you 5-year data to tell you what happens if you keep treating for a long time. And the side effect profile is minimal. So we've had the tabs, we tried the jabs, and I'm not going to talk about occipital nerve blocks, so we're going to go on to the MABs. And there are currently 3 UK anti-CGRP monoclonal antibodies. They're all injectable. You can see this here on the right. If you want to buy them, they cost about £386 a month, unless you want to become a phone dealer and you can kind of want to be a month. They're clinically effective, and NICE thought they were cost effective. And they're all self-injectable, and there's home care schemes. 3 of them work on the protein, CGRP, 1 of them works on the receptor. But what about efficacy? Again, I'm going to show you some graphs. And the main point is not looking at the data, but it's looking at the placebo response in most of the things with an injection is a little higher. About 1 in 3 has a placebo response. But actually the treatment response, so these are 50% responder rates compared to the orals, is pretty similar across the range to the oral medications. So they weren't as fantastic as we thought they would be until you use them in clinical practice. And in chronic migraine, the more difficult group, it's pretty similar to Botox. You know, they're not exactly the same populations. We're in the 40%. I'd ignore this kind of galcanezumab one. This is kind of, you've got to look at the placebo response is different, but actually the overall response is pretty similar. The difference between the new drugs, the MABs, is the adherence. The tolerability. They don't have any serious adverse effects. They have a bit of an injection site pain. There's a few post-marketing stuff. They don't affect your immunological system. They don't interfere with a COVID-19 vaccine. You don't have immune reactions. And the numbers of patients completing the trials was massive. Almost everybody, 95% completion. Compare that with the oral drugs, where up to 20 to 30% dropped out of the trials. So the issue is about these drugs, these new preventatives, is about tolerability. There are good studies showing that people prescribed oral drugs, what I call the prescribe and forget. Lots of people don't see them again. They prescribe this drug. Go on, you try that. That will help you. Well, actually, people don't take them. About 1 in 4 stops it at 6 months. Actually, 1 in 5 definitely doesn't take it for 12 months. And the persistence rate, and even if you switch them, is awful. So If you switch their drug, only about 1 in 10 takes that second drug. So the tolerability of these drugs, all but in an American population, is awful. Topiramate makes you dopey. It gives you paresthesia. It can make you depressed. Pizotifen gives you obesity. Propranolol can drop your blood pressure. Candesartan makes you dizzy, can give you renal problems. Epilim, sodium valproate, gives you spina bifida and neurodevelopmental delay in children. We're not seeing that so far in these drugs. They work. So the data from the trials tells us they work against placebo, but if you take them into real world populations who failed on 4 drugs, you start to see 1/3 to 1/2 of these patients, and this is all the studies, these are the ones here, have a 50% response. And actually, if you're lucky, 1 in 8 has a 75% response. And if you're very lucky, up to 6% or 3 to 6% have a 100% response. So they have abolition of their migraine for about 3 to 6 months. Fantastic, with good tolerability. So are they available? Well, now they are all available on the NHS in England. And my understanding is in Scotland, most of these are available. I'm sure Callum can tell me about that. And this is who they're approved for. And this is one of my money slides if you don't know anything about the MABs. So in summary, fremanezumab, you can give to everybody with chronic migraine. Galcanezumab and erenumab, you can give them if they've got episodic and chronic migraine. Botox, you can only give to chronic migraine. So sometimes you need to think about who you're treating. And do they work in really bad people who've had lots of drugs? And these are people who failed on 8 therapies. They're the people who come to my clinic who failed on almost everything, failed on Botox. And you can see in a real world scenario, rather than a clinical trial, you were seeing improvements in outcome measures in terms of quality of life, but also you were having significant 50% of people having some kind of efficacy, 1 in 3 having a 50% reduction, and 1 in 5 almost a 75% reduction in their high frequency migraine, having failed on 8 previous therapies. So these are definitely a step forward. Do they work for long periods? They work for a year. You can see the studies, if you follow them up on an open label basis, you see sustained effects. And actually the response rate, which are 50%, 75% and 100% appears to be maintained. So 1 in 5 having 100% resolution of their migraine for a year, one could argue is close to cure, which is what some patients want. So these drugs are a step forward. So I've summarized why I think they're a step forward. They're the first designer drug as opposed to being repurposed. They're better than oral, but actually we'll find out over time if that's the case. They work rapidly within the first month, sometime within the first week. We've got data that 1 in 3 at least who respond within the first 3 months continues to have that same response. They work in some, but not all. And so far the safety is good, but hypertension is being identified in its very early days. So back to that question I posed at the start, I'm almost finished. What happens when you stop prevention? The question I ask people is, how long am I going to treat people for? Well, we've got some data from topiramate because we did a trial on that quite a while ago, and some people have a carryover effect. But the only study I could find with the new drugs, and I've got to commend Lilly for this and Emgality or galcanezumab, because they're the only ones with the data. It shows that actually there is a carryover effect. So this is the treatment trial, and then they stopped, but they followed up their clinical data. And what you see is possibly 1/3 to 50% start to creep up within about 4 to 5 months towards where they were. And these are population samples. So these are symptomatic therapies as opposed to disease modifying therapies. And I'll leave you with some questions before my last 2 slides. What don't we know? Should we be giving this or should we be giving Botox first? Medication overuse. If you've got triptan medication overuse, you can give that and it will make no difference whether they're taking too many triptans. It works. We don't know what happens if you're taking opioids. We argue about what the stopping criteria are. My personal view is when your migraine frequency gets down to about 4 to 6 problematic days a month, that's when you stop, not too soon. What do you do if you don't respond? And what happens when we switch MABs? and there's data coming out from that. And we really don't know a few things about the long-term safety. I hope this isn't the emperor's new clothes. And finally, like my colleague, Callum, I'm going to leave you with a taste of the future. Callum talked about GPANTs as acute medications. Well, actually, there are now 2 early studies with small molecules, which are oral medications, which appear to be beneficial with migraine prevention. And it remains to be seen where they'll be used in the migraine prevention armamentarium, but they're probably going to become available in the UK in the next 2 to 3 years. And with that, I'll say thank you. I'll commend you all to the Migraine Trust. I invite you all to become members of BASH, and thank you for listening to me talk about my passion headache.
Wonderful, Brendan. That's really very good. And you covered all aspects of it, not just what the choice is as to what do you do when you stop or when you start. So I think, I'm sure there will be lots of questions, and I have made some notes of it. So we'll have lots of questions at the very end. So I move on to the next speaker. And our next speaker is Louise Rusk from East Belfast. And I do apologize that when I sent the invitation, I put her as a trainee in general practice. She's actually a trainer. We wouldn't ask a trainee to come and present in the BASH webinars. So I do apologize, Louise. Louise is also a trustee of the Migraine Trust, and although she works in primary care, she does the headache clinic in secondary care in a hospital. So Louise is going to talk about all these stuff, acute and preventive, what our general practitioners should be doing, because she's got double hat, the secondary care because she provides a service there, and primary care because she's a GP. So I think coming from her would be a good perspective of how and what challenges a primary care general practitioner has when they deal with a migraine patient. Thanks, Louise.
I'm just going to share my screen now, and thank you, Fayaz. Good evening from Belfast in Northern Ireland, and it is a pleasure to speak on behalf of BASH on migraine management and primary care, and I've got 10 minutes. So it's a pretty short talk, and I'm going to be talking about the practical suggestions for how to manage these patients. So these are my disclosures. And GPs here are not going to be surprised to know that, you know, headache is very common presentation. It's the most common neurological presentation in primary care. I mean, I think that this study that said it was 4.4% of consultations is probably an underestimation, because it's to do with coding, and headache will tend to be part of another consultation as well. But I think it's important to say that GPs actually manage the vast majority of their patients with headache without referring to secondary care. So only a small number of patients, so 2 to 3% of patients will be referred to secondary care. But because it's so common, still manages to make up about 30% of neurological referrals. And I don't know if you can see this slide, this part over at the right, and this is looking at what influences GPs' referral behaviour for headache when there isn't a clinical indicator. So there's going to be a combination of GP characteristics, like how comfortable they are with managing headache and tolerating anxiety, and then of course patient pressure. And I mean, any of you who are working as GPs and know that we are now dealing with a massive demand in primary care, your threshold for referring may be affected by that and just time management. But I actually looked in 2018 at the what is coming through to my clinic, because I thought I really want to know, what do GPs want? And it was interesting because they mostly want to know about diagnosis of, so 64% of the, so we're looking at 100 referrals, 64 of those were actually what is the diagnosis here. And only the 36% was about management of headaches. So I thought that was interesting. Of course, Callum has gone through the acute management with us, and this is our GP menu. I think we're obviously not going to be getting Ditans and Gpants for a while, but this is our GP menu. It's important to remember that important message that it's not stepwise, you know, we're going in hard and heavy at the beginning of the migraine. But from a practical perspective, thinking about the antiemetics, I think that's a really important take-home point. Antiemetics augment the benefit of the other medications, but they have a, you know, metoclopramide will have an independent benefit on headache pain itself, and that might be new to some GPs. I find it really helpful on a practical sense, though, to make sure to write on the prescription the specific migraine advice, as opposed to just letting the auto thing that comes out from your prescription generator, you know, the metoclopramide 10 milligrams TDS PRN. That's not really helpful to somebody with migraine. But if you're putting on it metoclopramide, take at earliest onset of migraine, and you know when it can be repeated. And then I also tend to put on it about not using it more than 2 days a week on average, really continuing to drive home that message each time they're looking at the prescription or the tablet box. So triptans, just want to say something about triptans. So triptans are currently thought to be the best treatment option for migraine. They were hailed as a wonder drug when they first came out. The thing is, they're specific. It's not the same, you know, you can't use a triptan for your knee pain or your back pain. I'm giving you something specific for your migraine, and they are effective. And we just had to look at Callum's slides of numbers needed to treat to know that. But this was a huge study that was published only in February there, a Danish study on 25 years of triptans. And they were looking at almost 7.5 million individuals and the prescribing and the uptake of triptans. And over that 25 years, there's been a slow and steady increase in the triptan prescribing, but there was a low persistence or adherence rate. So almost half of patients who received a triptan prescription and got it, they only got it once in a 5-year period. And the other thing that was was interesting, but it is consistent with other studies, is that the majority of people who discontinued triptans actually only had used one triptan. So we know from the guidelines in Denmark, and the guidelines were that you would use 3 before saying that somebody was a triptan non-responder, but actually at best 10% had even tried any other ones. And of course, triptan use increased in parallel with triptan overuse increased in parallel with the triptan use. So where do we come into that as GPs? They actually did ask that question: do GPs have a role to play in this? Now, it could be that the triptans themselves are to blame, but we also have to think about what are how we counsel people with triptans. Do we just do the prescription and say this is good for your migraine and send that off, or are we saying to them, look, you know, this may give you the side effects of X, Y, and Z. I would ask you to come back to me if it doesn't agree with you, and we'll try something different, or trying to explain to people that they really need to use it for at least 3 headaches before they can decide if it's ineffective. So how is it that we are counselling them? Are we confidently and clearly explaining what to expect from triptans? So here are the available triptans. And again, in that study, over 90% were obviously oral triptans that were prescribed, and 2% were subcutaneous, but a very, very tiny, like 1.2% of and all of their triptan prescriptions were intranasal. So we're probably really underusing that. of course, Callum had mentioned how useful they were. So my triptan tips, they don't work every time. Sometimes if somebody wakes with a headache, it's well established and the triptan won't work. Advise them to try it for at least 3 headaches before switching, and try 3 triptans adequately before considering triptan resistance. I'm not going to go over this bottom part of the slide again because it was already mentioned earlier today. But just to signpost to you, I know that any GPs that are sitting here, we're expected to be jack of all trades and remember all of these guidelines, but I am delighted anytime I can give a good one. Here's the one I would recommend for headache. I would bookmark and suggest bookmarking and favoriting that one. And you can, this is the National Headache Management System, and you can click onto the tabs and you'll get treatment tables like that and patient information leaflets to support your prescribing. Prevention. How on earth are we going to manage this in our very short 10-minute consultation? Because we are trying to carry a lot in general practice. What I would say to you is that, make time work for you in GP. In the hospital clinic, myself and the neurologist, they have a long time to sit and go through everything with patients with migraine. But in general practice, we don't have that luxury in one sitting. But what we do have is the benefit of checking in and that relationship where we can do short, frequent consultations. So don't try and do it all in one go. Here's how I tend to go with prophylaxis. So I would tend to have that first, once we've made the decision to go for the migraine preventative, start very low. And I mean, even like I'll give an example, amitriptyline, I quite often will suggest starting it on half a tablet at night just to get somebody onto it and then increase. So start very low and check in again, either you or your practice-based pharmacist. So it doesn't have to be you doing this, to review the tolerability and efficacy of the medication. So, and as Brendan had said earlier, we're talking about going up in to a target and sticking at that maximum tolerated dose for 8 weeks. So, it's hard for a person to think about doing that by themselves if you're not saying, come back to me at the end of this. So I'll give you an example. Today, earlier on today, I had a patient and she telephone thing said, patient wants you to ring because she needs to change her migraine preventative medication. So I had put her on candesartan quite a wee while ago, 2 milligrams, and she hadn't come back to me about it. And then 4 weeks ago, I increased her dose from 2 to 4 milligrams. And she was now ringing 4 weeks later and she said, it's not working. So I said, tell me a bit more about that. And she said, it's not working because I'm still getting headaches. So it was a good conversation because we had a diary, and these diaries are good for focusing me and the patient, and also for scanning into the notes. That cuts down on your documentation time. But what had happened was she had had 6 weeks of daily headaches before she went up to that 4 milligrams. And then when we reviewed the headache, her headaches had actually gone down to 3 or 4 a week. And so it was a matter of hang in there, we're going to give it a bit longer. There is actually a benefit, and talking about a realistic outcome. So just before we wrap up, I would say diary is really useful tool, and set your target with your patients and review. Realistic outcome, as Brendan covered earlier. I think it's important to manage patient expectation, and to point out that they still do need an effective acute treatment whilst they're using preventative treatments. Use the dose, high enough dose for long enough, and do consider, we're very good at starting medication, but not maybe so good at stopping it. And we do think about stopping migraine preventions. I'm just going to mention one little bit about contraception. Remember that we are dealing with women of childbearing age. And as Brendan said, the migraine itself is not a fatal disease. So we have to think about the whole picture. And it's important to, we don't want people getting pregnant on any preventative medication, but especially with topiramate, it's teratogenic and it's an enzyme inducer, so potential to interact with your contraception choices. and candesartan teratogenic with its worst effects in second and third trimester. So those conversations, I've just put up the flags on the right here that come up if I were to go and prescribe it on vision. Remember, it's not all about drugs, and we can be complicit in making patients think that it is that drugs are the answer. Don't forget to check in. How are you doing with anchoring your wake times and managing your sleep? Are you managing to build in that regular exercise or the relaxation that we talked about in the last consultation? And then signpost, because it is about empowering patients and self-management. Of course, I'm going to signpost the Migraine Trust, but here we've got a useful. They're doing we are doing virtual managing your migraine days, for example, and lots of useful information. And two brilliant GP-ESI colleagues on the National Migraine Centre are doing podcasts. So whatever works for your patient, it is about empowering them to manage this chronic condition. And whenever you've done all that, I would say a failure of 3 prophylactic medications, then it's time probably to think about a secondary care input. So thank you. That's a whistle-stop tour through primary care, and happy to take questions.
Thank you, Louise, for primary care perspective, comprehensive messages. I'll start the questions from you, Louise. David Watson just asked a question and said that he has seen a few patients who were very nicely controlled with chronic migraine with different things, including Botox. And as soon as they have had the COVID vaccine, they have reverted back to chronic migraine. Considering you work in primary care, have you come across that in your practice?
I actually haven't. I've had a few headache consultations, but they haven't been in our patients with migraine, I have to say. They've been non-migraine patients and with pretty vague, unclassifiable headaches that are lasting for a couple of weeks. Mm-hmm. But I haven't come across that.
Callum and Brendan, have you come across any?
Go on, Callum.
Callum.
No, not particularly many. Headache seems to be a common effect with COVID, and certainly there are a number of people who've had chronic migraine better treated that have got worse with COVID. I presume it can happen with vaccines, but it's not something I've seen particularly. No, it should hopefully settle, I suppose.
Brendan?
Yeah, I've had about 2 or 3 types of things with headache. We had 2 cases of the thrombocytopenia and CVST. Forget that. That's I've certainly had new daily persistent headache in the context of COVID, having COVID-19 and having new daily. But actually, we've also seen some people after, it's the AZ vaccine I've seen it more after rather than the Pfizer vaccine. We've had some people whose migraine's been well controlled and actually for no reason, everything's gone pear-shaped, and our nurse specialist, they phoned our nurse specialist, and I've had a few people come and see me in the independent sector saying, there's nothing happened in my life apart from the COVID-19 vaccine. I haven't got a mechanism. I'm assuming it might just be some kind of inflammatory response which is inducing or activating the pathophysiological mechanisms in migraine. That would be my thoughts around it.
Good, thanks, Brendan. Callum, there is a question from, I think David Watson asked this. No, I think somebody else. I don't want to name everything to David Watson. He's asked quite a few questions. IV indomethacin for status migrainosus.
So IV indomethacin is a good treatment and certainly works. It's got a poor side effect profile. It's not something I've used in the acute treatment of migraine, but I reserve it for indomethacin specific headaches such as hemicrania continua. As a good non-steroidal, one might think it might be worth considering, but I don't think there's any evidence behind it, and certainly I haven't used it in that regard, so I can't really give a good answer to that.
Yeah, I haven't used it either, and I would have thought that if IV indomethacin makes people better, you start to think about whether they've got hemicrania continua or indomethacin responsive headache. Brendan, what do you think?
Yeah, I'd agree with you, really. I've never used IV indomethacin. We've used IM indomethacin and IM diclofenac in the past, just largely in acute severe migraine, but I've got no experience, so no, don't know.
Okay, one more question is to Callum. Somebody asked the question that, would you start sumatriptan with 100 milligram and lower down to 50 if there are side effects, or you do the other way around?
Well, with the sign 107, which was published in 2008, we suggested 50 milligrams starting. But the evidence really is that the 100 milligrams is better. I think the same is for ibuprofen and non-steroidal. So I think it's better to start with a bigger dose and work down if it's not effective. That would be my view on it. And so I would suggest 100 milligrams of sumatriptan is your good first starting dose of a triptan. Often if you go on a smaller dose, they stay on it rather than going up.
Brendan, I've got two questions that I wrote it myself. When you talked about 30%, 50%, 75%, and 100%, my thought is that the higher the number of days of headache, the lesser should be the response. So if somebody got a 24 days of headache, I would say 30% is a better outcome. You don't want to be talking about 6 days of headache and having a 30% response. What do you think?
No, I totally agree with that. I think we all see people who have high frequency headache, and particularly the people who have daily background headache with migraine on top. Getting a 30% response and you're over the moon in that population. Setting yourself an unrealistic target of 50% or 75% or 100%, I think is setting you up to fail. Just for the audience, really, the 30% response was set because chronic, as you know, people on the faculty know, is 30% is an achievable thing. You see about, if you give anybody preventatives, oral preventatives, you'll see about a 20% placebo response, which is your friend in clinical practice, but actually it could be a placebo response. Injectable is a bit more than that. So I'd totally agree with you, Fayaz. The higher the frequency, you mustn't set yourself up to fail. I'm always surprised when I see somebody, I think, 30% is as good as we might get, and they go down to 50 or 60 or 75%. And I've seen that happening sometimes with Botox, but more commonly with the MABs than any other therapy I've ever seen.
By the way, what do you think is a high frequency episodic migraine? 8 days or 10 days?
I think high frequency episodic migraine is 10 days, but that's my view. I don't think we argue about that. The reason I choose 10 days, I suspect, is because you then get into a situation where triptan overuse becomes a big issue. And I think 8 days is a bit arbitrary. I talked about what I do in terms of stopping criteria. I think the license for these drugs is 4 days a month. But actually you can probably, people I see who are having 4 days a month, unless they're really severe migraine, they don't want to take a daily tablet 30 days a month or something like that to get rid of those 4 days. They're quite happy to take acute meds first of all and just take acute meds. A once monthly injection is slightly different. But actually they start not to want to take meds 8 days a month because that's twice a week probably. It starts to become, so I think 10 days, it's anecdote, can't back it up. I know that Allergan a long time ago said that when you get to 10 to 12 days a month, the chances of you going on to having higher frequency within a year is significant, but I've never seen good data for that.
Well, I mean, I have definitely seen that if you stop Botox, when people have 10 to 14, they relapse very quickly.
Yes.
That's why our stopping rule has always been less than 10 days in single figures for a period of 3 to 6 months before you stop the treatment. So, I mean, my take is also 10 days, basically.
I agree.
While we're staying with you, expectations. I think the best people to get the expectations right in the community would be the primary care. So Louise, what can you do, or what can the GPs do to get the expectations right of the patients? Because they often come to secondary care thinking, oh, I'm going to see a super specialist and I'll be cured of headaches now.
Yeah, I think that explaining that what we're trying to do is, calm the migraine brain down to reduce the number of headaches and the severity of them, but that we can't get rid of your headache, or it's unlikely that we are going to get rid of your headache. And saying that early on is important. But it's saying it early on and repeating it, because that patient that I said to you about the candesartan, I know I will have said that to her before I started the very first time. And yet she's coming back after an increase saying, it's not working because I'm still getting the headaches. So it's reinforcing that thing that what we're trying to achieve is to reduce the whole migraine picture. It's not easy.
Yeah, I mean, I know our Vicky Quarshi, the late Vicky Quarshi, she set up quite a lot of headache school in Hull. So basically, the nurses go and have a little bit of a session with patients, basically telling them, look, you're going to see a specialist, but this is what you're going to expect, what to happen. So by the time they come to secondary care, they know exactly what they're going to get from treatment. So I think that's a thing that primary care people should be able to take it on.
Oh yes, even about what to expect from specialists. But actually, there's often a disconnect between what we would say and what the patient expects anyway, and that can be a driver for referral in the first place.
Brandon, CGRP monoclonal antibody, they don't cross the blood-brain barrier.
No.
How do they work?
Hey, so well, we think probably at the trigeminal ganglion, possibly, but we don't know really. There's this, because they don't get into, well, we don't think they get into the brain because they're large molecules. So the theory is possibly at the trigeminal ganglion where there might be some crosstalk. They may be working peripherally, but I just don't think we absolutely know. I think it would be, I think I put on one of my slides, would we see a better response if we infused CGRP into the CSF space, so we did get it centrally, and I don't think anybody's going to do that. But
I mean, intrathecal.
Intrathecally, I apologize. Yes, I apologize. Intrathecally. So I think we argue about that, and I don't think we know. And I think the same thing happens around Botox. You know, it's Botox works peripherally. A guy in the States says there's branches of intracranial projections from sensory afferent nerve fibers which traverse the skull and get to the outside. So, you know, I still think there's more science.
Staying on the CGRP, actinizumab, there is a claim that actinizumab can work for status migrainosus.
So that's what I'd probably see that being used. But actually, all of these drugs could work for status migrainosus. All, you know, if you look at the studies of all the MABs, several of them work within the first 24 to 48 hours. They get into the system very quickly. We did the eptinizumab trials, and I have to say they worked really, really rapidly. And I would see IV eptinizumab being used in secondary care. I think the concern I'll probably have about it being used in emergency departments is that they're probably going to be given sometimes to people who haven't got migraine, and it'll just affect the headache mechanism, and there'll be some people with other headaches who get managed with eptinizumab and might have other conditions. But I think there's definitely probably a role for eptinizumab in status migrainosus once it's confirmed.
Okay, Callum, somebody asked the question, sumatriptan is definitely safe in pregnancy. Do you think the other triptan would be safe as well?
Yes, I think this is, so it's like the amitriptyline nortriptyline question, isn't it? So you've got long-standing evidence for amitriptyline, perhaps at low dose in pregnancy, but going across to nortriptyline, you don't know whether it's a class effect. I think the same thing is for triptans, to be honest. The registry data is sumatriptan and naratriptan, and there's limited data for the rest of them. So I think the safe practice is going to be sticking with sumatriptan for treatment in pregnancy, although probably the other ones are safe. I don't think we have enough evidence really to confirm that in detail.
It's just that a third of people would not respond to sumatriptan. Would it be good for the pregnant ladies to try another triptan?
It is, with discussing risks, it is likely to be safe. And I think if you discuss the risks adequately, that would be reasonable, but you would have to discuss the risks. And sumatriptan is the one where there is that good cohort of evidence that it is safe.
Callum, there is a new version of subcut sumatriptan 3 milligram available. What do you think? I mean, it's only for cluster, or you can use it for migraine as well?
I think it sounds quite attractive, doesn't it? The advantage in cluster is that if you've got that 2 times 6 milligram maximum, you can use it for more headaches, so say 4 instead of 2, and that would be very attractive in cluster. It's potentially going to have less side effects, I suppose, so it would be reasonable in migraine. But I think we see. I certainly think it's an encouraging development. But I suppose I don't know quite what the cost is compared to 6 milligrams.
I mean, I haven't used it. Brendan, have you used that 3 milligrams?
Yeah, I've used 3 milligrams. It's my understanding it's got the license for migraine, so you can use 3 milligrams. So the people we're choosing to use it are people who've used the 6 milligram injection. It works for them, but they get lots of side effects. They don't like it. So we give them the 3 milligrams to see, and we've seen some benefits. It's not got the license. As soon as the person came and talked to me about the 3 milligram, I thought cluster 4 times a day. Here we go. So that's an off-label thing, I think. But I think we just got to get the data for it. It stops people ripping open their injections and taking the stuff out themselves, and as I'm sure all of us have seen people do.
Yes.
And cost-wise, they're asked the company. I better not say anything, had I?
Yeah. Right. I'll put a question to Louise, and then I'll go through, while you're answering, I'll go through some of the very late questions coming on. Louise, the other thing that I think primary care physicians do is to try and monitor and manage or educate people for medication overuse, because a large number of people that I see come from primary care have been overusing painkillers. Not that this is a fault of the primary care physician, it's just that they buy over-the-counter painkillers. And most of them have got codeine. Could primary care physician to their patients do something to address this issue?
Yeah, I mean, I think that's a really big educational need as well, because I don't think there's widespread, I mean, it might be speaking out of turn, but I don't think there's widespread understanding that even if codeine is used for knee or back pain, that it can trigger the chronic headaches in a migraine patient. So that's one thing. Can we do anything? I totally agree with what Callum was saying, or Brendan, one of you said that the best treatment for medication overuse is the prevention, and getting where we can be, what we can do in primary care is to have that message of no more than 2 days a week and to put it on the prescription, so that the message is continually going out there. And the other thing is, I've noticed we have some people who get triptans and somebody's put them onto repeats, but we put a minimum day block on so they can't request it actually any earlier. So that reduces the number of prescriptions going out. So there are plenty of things that GPs can do. It is a wee bit about awareness though.
Callum and Brendan, I know you're vice chair of BASH and you're secretary of BASH. Could BASH do something asking the government to take away from the shelf all the painkillers with codeine in it?
Oh, I'd love that. That's a really good thing to do. I suppose the challenge is that pharmacists are independent companies, aren't they? And so that's a difficult way in. But I think getting education into individual pharmacies so that we're recommending the correct thing. I had a lovely pharmacist who tried to convince me that Solpadeine was better for my migraine than aspirin 900 milligrams, at which point they got a bit of education. But it is something I think we have to publicize. And certainly in 12 years as a consultant, I'm seeing patients having been told about medication abuse headache much more. So it's certainly a message that is getting through to a lot of GPs for definite, and patients do seem to understand this, which is a nice positive thing, I think.
It is, and I think
chair of BASH, would you want to drive this motion from BASH platform?
I don't think the pharmacies have to. I think it would have to be on the packaging. If I was a health economist, what I would probably look at is the simple win-win is to look at every practice in the country who's having individuals who are taking some kind of opioid analgesic more than, let's say 10 for argument's sake, a month, 10 days a month. And of those, identify how many of those have got headache in excess of 15 or 20 days a month, and actually target all of those people with a program. And actually, I think you'd do two things. You'd possibly reduce impairment for possibly 25 to 50% of the people you identify, and you'd cut the drug budget, and it might even as a project pay for itself. So, but I can't see government doing anything like that in the near future.
Okay, Brendan, there is a very interesting question, and I think I have some experience with the Botox in it. Somebody asked the question that there is a chronic migraine vertigo, and the patient is asking to put her on the CGRP MABs.
Oh, that's a really good question.
The patient has very little headache.
Okay, so that's a really good question. One of the things that struck me about using some of these anti-CGRP monoclonal is actually the other symptoms that get better rather than just the headache. Some of the kind of non-specific nebulous things. What, for those of you who are in the headache field, we call the kind of most bothersome symptoms. So, as we all know, some people with migraine have really disabling headaches. Some people have disabling aura. For some people, it's the neck ache that's problematic, or the sensitivities. So certainly, I think if they have migraine at other times and they have vertiginous disturbance and what may be migraine-related vertigo prominently during their headache attacks and at other times, it would be interesting to see if it improved it. But equally, what I'd probably want to do is I'd want to make sure they haven't got any other comorbidity that occurs with migraine. As we all know, Meniere's disease is more common in migraine than the background population. So they could have two things. But I think treatment, and actually, it could be an area where one of the companies wants to do a trial in the longer term. But I think doing a trial of it, it's a pretty harmless therapy. They'd probably have to pay for it, because I can't imagine they'd get it licensed by the NHS.
Well, I certainly got experience with chronic migrainous vertigo responding well to Botox. The patient has very little headache, and headache is not a problem. And I've got some people with very unpleasant auras responding to Botox, and I've got a few hemicrania continua responding to Botox. So I see no reason why MABs couldn't be tried, but would we get an approval from the CCG? I probably think we don't.
Probably, I probably won't talk about it on on something that's going to appear on YouTube. But I think if it can be obtained and it can be delivered, then I see no reason, as long as there's no other options available to try that.
Louise, there is a question, and you might be able to answer that. What's the natural history of chronic migraine in post-menopausal women?
So migraine attacks in general will tend to improve post-menopausally. That's more in migraine without aura than in migraine with aura. So yeah, in general, the difficulty though is when you're talking about a chronic established pain syndrome. So I'm not totally sure if that applies to like the chronic daily, chronic migraine. I don't know what Brandon and Callum would say about that, but in general, even high frequency episodic will improve after the menopause with a perimenopausal worsening.
Yeah, if they have perimenopausal worsening, and often if they have headaches that are quite triggered by menstruation, I think there's a more sporting chance of it getting better. And I would say it's something that happens, and there's a reasonable chance of it improving, but it's not guaranteed.
Yeah, there is a question from David Watson and Botox in pregnancy. I mean, I've got 45 patients that we just published. Have you guys any experience of Botox in pregnancy? I think we need to set up a registry.
Yeah.
Yes. Yeah.
I got one. I quote your paper. I give any person we see who's got really troublesome migraine in pregnancy, and we don't see many because actually, you know, it gets better in most people. We counsel them about it's not licensed. We give them your paper, a copy of your paper, and say, you know, here's some data. What do you want to do? And so we've just kind of informed consent, and off we go, like yourself, really.
Yeah, I've done this. I've done exactly the same thing. You know, I've got about 3 or 4 who've gone through pregnancy on Botox, and I've always used the Allergan registry and put them in through that as a sort of a belts and braces thing. But it seems to be safe, and as long as they're adequately counselled and aware there isn't complete evidence, I think it's reasonable.
Somebody asked a question about new daily persistent headache post-COVID.
So, does anybody else want to answer, or?
Yeah.
Okay. You know, about 70% of people with COVID get headache. Even my consultant colleague who runs a headache service got new daily persistent headache with COVID for a period for about 3 months. Anyway, you know, be careful what you wish on yourself. We manage them with non-steroidals. That's what we tend to go. We give them naproxen has got some data as prophylaxis, so we give them, as long as there's no contraindication, we give them regular naproxen, and we treat it as a post-viral headache or a post-infectious headache. We've seen some, so if it's a de novo new daily persistent headache without headache before and without migraine before, so far what we're seeing is a good natural history. But the numbers are very small.
Okay, just one more question. Any of you would like to answer? I don't mind. Are there any treatments that are better for sleep architecture?
Good question.
Yeah, Brendan?
So I didn't talk about it in my thing. Melatonin. For everybody who's on the call, just put melatonin, Journal of Neurology, Neurosurgery and Psychiatry, melatonin, JNNP, and there's a study comparing melatonin, I think it's versus propranolol 160, and it shows pretty similar efficacy, and it doesn't muck around with your sleep architecture. Everyone thinks that tricyclics, amitriptyline and nortriptyline induce sleep, but I'm told by a sleep doctor that they induce sleep, but they wreck your sleep architecture. So we tend to give melatonin and then look for a plus or minus another preventative, because I don't think melatonin is. And then just doing all the simple things, you know, is going back, giving them a sleep hygiene leaflet, making them read it, making sure they do all those things. They don't have coffee at night. They don't exercise at night. They don't look at their, whatever it is, on their smartphone and use a bedroom as a bedroom. You know, the simple advice that we give for that. And it works in some.
If you make them read small print sleep hygiene leaflet.
Yes.
I have to say, I haven't found a really good thing so far.
Yeah. So what dose, Brendan?
Callum, something about long aura or hemiplegic migraine. Do you think Tryptons are safe enough now with no, you know, evidence that it's do any harm?
So I suppose migraine is a brain disorder, isn't it? So it's not a vascular disorder. Certainly Triptons can cause vasoconstriction. You know, I remember having this question with a group of a pile of headache neurologists, and the opinion really for a majority was that it is actually safe and it is reasonable to use. And I certainly don't restrict triptans in patients with prolonged aura. Clearly, you have the discussion about the uncertainties around it, but I've certainly had a number of people have no problems with it. So I personally use it and I'm fairly comfortable with it. But migraine's a brain disorder, not a vascular disorder.
Thanks, Callum. One last question to Brendan. That's from me. You worked for the NICE guidelines in 2012. I did it in 2015. I'm not a big fan of valproate. I think you've shown that it has got good evidence, although the network meta-analysis that NICE did had got no role for valproate. Correct me if I'm wrong. Is valproate really good? I have got very negative experience of using valproate.
I don't think it's really good, but I've certainly I only give it to men anyway.
Absolutely.
Because I just don't think it's worth taking the risk with women. I think I've seen people do really well on valproate who haven't responded to other therapies. I gave some data on dosing, and I struggle with dosing, I have to say. I think you have to have at least 1,000 milligrams minimum. The studies suggest somewhere between 600 and about 1,500, if I remember rightly. It might be in 1,600, but actually, I think you have to go up to 1,000 to 1,500. I don't think it's devastatingly fantastic. Mm-hmm. My personal view is the drugs which have got really, I see working the best. I think topiramate is a Jekyll and Hyde drug. Mm-hmm. In those people, it works. It really works, and the evidence shows that. I think beta blockers certainly work, and I think tricyclics certainly work. I'm not a big fan of candesartan in chronic migraine. I'm yet to see people do really, really well on it, but that's my personal experience as opposed to data. And I talk to colleagues around the country who say, yeah, actually it works. So,
well, I've had very good experience with candesartan.
Yeah, likewise.
So have I.
So I'm doing something wrong. I must be, I got the dosing wrong. I'm doing it too quickly. So anyway, that's why it's such a difficult condition, and the natural history of the condition, I think, doesn't help us.
Yeah.
The other thing I got a bit surprised seeing your network meta-analysis of fluoxetine. I mean, we did a very big study in '98, and it was a negative study.
Yeah.
I am not aware of any positive study.
So well, this was a systems meta-analysis of all the data. It's PLOS online. It's a reputable group, and it's looked at that, and you can see that SSRIs are involved in that. And if you look at most of the guidelines across the world, SSRIs and most SNRIs are not in that. So you're right. You're right. I was surprised at that.
Yeah, I was very surprised at that.
And the data they suggested on flunarizine is there's damn lies, there's lies, damn lies, and there's stats, isn't there? Is that somebody says?
Something like that, yeah.
You get the right meta-analysis and you do the right analysis, you can make anything look good.
I mean, if I show you the network meta-analysis of NICE, it's totally different to the one which you've shown.
Absolutely.
So I think the NICE doesn't like crossover studies, and they didn't even wanted to appraise candesartan at all, because they say it was a crossover trial.
So as we talked about probably earlier on, is the NICE guidelines are really, really robust, but actually it's the scope that matters. And if the scope of the assessment is wrong, and that's what I learned very quickly in this NICE process, if the scope is not what you'd like it to be, then they throw things out, and that's really challenging.
You mean it's too narrow?
Can be.
Okay, just the one final question coming to Louise. Give me a two-liner message for a primary care physician, which patient they should be managing with prophylaxis and which patient they should be sending to secondary care.
You can try to manage any patient with prophylaxis, because we've got a wide range of prophylaxis. And who would I send? I would wait till we've tried three prophylactic medication and failure of that.
Which you choose?
Which three? Oh, well, It depends, obviously. If but I would go like propranolol, candesartan, topiramate, amitriptyline. I'm happy. We'd be happy with any of those in primary care. And the other thing I would say to the GPs is somebody will say, "Oh, propranolol didn't work for me," and it's maybe been a 28-day prescription. It's okay to start again with another beta blocker and try and work up and give an adequate trial, because it's the adequate trial that needs to happen.
Because I usually say to my GPs here, if you know that the diagnosis is right, then try propranolol, amitriptyline, and candesartan. I don't tell them to start topiramate. You would agree with that, Brandon? Topiramate, I'm not very keen about.
Yeah, I think it's a very effective drug, but I think the tolerability is not good. And I counsel people that they might not like it. And I use children's doses. I use the 15 milligram sprinkles and do it very, very slowly. And I think it's a Jekyll and Hyde drug. I think there are some people who tolerate it and some people who can't take even 1 or 2 tablets.
Either love it or hate it.
Yes.
And a lot of GPs don't want to prescribe topiramate, which is fair enough.
Yeah. Well, gentlemen and Louise, thank you very much. I think it was a very nice discussion. I thoroughly enjoyed it and I learned quite a bit. So thank you for your time in the evening. And we look forward to seeing you again in some of the webinars later on in the year.
Thank you. Thank you for inviting us.
Thank you.